Pugly flows in. Push bhi आ बाजू. The talk is loaded here. Yeah, आप ही Okay, आप ही दीजिए. आप ही दीजिए.
So, invite Dr. Bhupesh Shah to talk on Finerenone is a proven therapy for diabetic kidney disease patients. Dr. Bhupesh Shah is a professor of cardiology and very well known cardiologist who have helped in establishing the cardiology in the state of Gujarat and Ahmedabad. He is practicing at SVP and HCP hospital. And thank you. Over to Dr. Bhupesh Shah.
Thank you very much, and Dr. Kamal and team, good evening. This is the topic. So first of all, there is the how to live 100 years before developing the coronary artery disease. That was a suggestion by the Bronwal. And Dr. J.S. Hiramath, I think his slides are very popular, how to live beyond 60 years. So I think that is also very important, slides were. The third thing, Bronwal has also mentioned that because of our heart treatment, many patients having the heart failure. And normally we believe just like the preserved ejection fraction, we usually preserve our life that I will do something after 60, something after retirement, and it's better to stay at home rather than in the hospital. So whatever the drugs which can reduce the hospitalization for the heart, which is very important. So this is the patient. Let us see about the cardio-kidney metabolic status of this patient. As Dr. Kamal has given this 55 years old patient having a NYHA class 3, creatinine is 1.6, eGFR is 45. Albumin creatine ratio is 330. So this patient falls into the mildly reduced ejection fraction, and patient is having a CKD, but this is the albuminuric CKD. So we have to little bit think more on that. Why this is important? Because so many, we have seen regarding the reduced HEPREF, and there is also high unmet need. Heart failure, particularly those who are having the ejection more than 40, because there is a rising prevalence and poor prognosis too. Hospitalized patient having the preserved ejection fraction mortality is definitely high. So that's why this is a very important population where we have to treat them properly. There is a limited approved treatment for the mid-range preserved ejection. The 4 pillars which are there, again, I think they are going to 4 pillars for the mildly reduced and the preserved ejection fraction. Because our patient is probably from the million, the patient, the diabetes and the CKD, I think this is a very important subset of the patient. Because CKD in the diabetic patient, there is a high burden of this combination. And there are the millions of the patients having the HEPREF, mildly reduced, there is MRAF and the preserved ejection fraction. So we have to look into that subset of the patient too. But as a patient having the diabetes, probably it is said that every year I think we should look for the protein in the urine, albuminuria is there or not. That is a simple and yet important early predictor of the heart and the kidney disease. And according to the urinary albumin creatinine ratio, we can see the mortality, morbidity, kidney outcome, cardiovascular outcome, they also change. So, which is the important drug? That is the Finerenone, we know that improved. So, which is the other drug which can be added in the patient? Finerenone, we know that it improved the cardiovascular and the heart failure outcome. There is the Fidelity and the Figaro trial. We know that there is 22% reduction in the first hospitalization of the heart failure. There is a reduced risk of the cardiovascular death and the heart failure hospitalization. And the new onset of the heart failure, it is again reduced, and the cardiovascular mortality is also reduced. And as a result of which, this is the updated guidelines which came in 23, and that is the recommendation that those patients having the diabetes and chronic kidney disease, the finerenone, which is recommended to reduce the risk of the heart failure hospitalization, it's the class 1A indication. And this is we can see what are the criteria for the CKD. So this is the patient. Now let us see, this is the 55-year-old patient, 330, that is the urine albumin creatine ratio, so it falls into the high risk category. And there are the various drugs. Patient is already on RASI, diuretics, SGLT2 inhibitors, statins, aspirin, beta blockers, but finerenone, I think it should be added to the patient. So what are the evidences for the heart failure of finerenone? So probably this is the trial, that is the Fine Hearts heart failure study. The design was that envisaged classes 2 to 4. LV ejection fraction 40 or more than that. So more sicker patients were included. So they are the hospitalized patient, recently hospitalized, or ambulatory patient having the high natriuretic peptide level, structural heart disease. And finerenone, according to eGFR, dose was titrated, maximum it was the 40 milligram. And baseline characteristic, diabetic atrial fibrillation, hypertension, and so on. So this was between the placebo group and the finerenone group. Why we want to see for the subgroup analysis? Because we want to know whether patient on ARNI, without ARNI, on SGLT2 inhibitors, without SGLT2 inhibitors, so what difference it makes. So there was no difference which was found. So that's why there is importance of this subgroup analysis in the trial. Randomization timing relative to most recent worsening heart failure event and the LV ejection fraction. See, if you look at this slide, that is more than 3 months or the no prior worsening of the heart failure, nearly 46%, less than 7 days, 20%, and 7 to 3 months, it is 34%. And the distribution of the LV ejection fraction, and this was the primary endpoints, that is the cardiovascular death and the total heart failure events in this trial. So, of course, we know that it is majority driven by the reduction in the hospitalization of the heart failure, but this is very important as far as the quality of the life is concerned. So, comparison with other positive, that is the MRAF and the HAPF trial, Fine Arts, Deliver, Empire, Reduce, reduction in the heart failure event, which is very, very important. But why cardiovascular death was not that much? Because these are the subset of the patient where we require to take very longer period to analyze the results. So that's why in MRAF and HAPF mortality is even little bit low. So that's why there was no advantages found as far as the cardiovascular death was concerned. But if we can stretch over the longer period, definitely we are going to get benefit. So does it mean what is about the clinical practice? So apart from this SGLT2 inhibitors, particularly in the MRAF and the HAPF, so now there are the positive trials we have for the MRS also. Recommendation for the MRS in the MRAF and the HAPF in the ESC guidelines, it's 2B. It was not for the HAPF in the ESC. ACC still considers it's a 2B classification. And comparison, how we compare this finerenone, spironolactone, and the eplerenone. Eplerenone, I think Dr. G. Kamath is going to talk on that. But spironolactone, it has the longer half-life. So it stays in the blood and the urine. We can detect the blood levels, and that's why it's a drug of choice to treat the resistant hypertension. Eplerenone is usually preferred agent, particularly when in acute event. But important thing is when the chronicity comes into the picture, like chronic heart failure, chronic kidney disease, the majority data which falls with the finerenone. And effect on the progesterone androgens is less with the finerenone, and important is the distribution. It is equal distribution, renal and the cardiac distribution, effect of the finerenone, which is equal on the heart and the kidney. Service in case of spironolactone and the eplerenone, they have more effect on the kidney rather than the heart. So that is the advantage of the finerenone. It's equally effective in the both sides, renal and the cardiac. MRAF and the HAPF, we have this Fine Arts heart failure study when ejection fraction was 40 or more than that. Emphasis HF, it was for the ejection fraction less than 30. The RALs again, ejection less than 30. So emphasis heart failure trial where ARNI was not available, SGLT2 inhibitors was not available, while in case of fine heart study, on the background, the many patients, they were on the SGLT2 inhibitors, on the ARNI. So this is again very important trial having the good background therapy guideline, director medical therapy compared to this previous trial. So let's look into the design of the fine heart umbrella program. That means if we combine all these three trials together and the more than 18,000 patient data, if we look, that is the fine hearts HF, Fidelio DKD trial, Figaro DKD trial. So pulling this data, so we can see that increased precision to the robustly assess the efficacy and safety of this non-steroidal MRA, finerenone. It's an important cardio-kidney outcome and enriched for the participant with the high burden of the cardiac, kidney and metabolic multimorbidity. And there is strong epidemiological overlap of the cardiovascular and the kidney. So this is the final comments that cardiovascular death, which was reduced in the fine heart failure hospitalization was reduced, kidney outcomes were reduced, acute condition, which was again, you can see the relative rate reduction, it was quite important, reduction in the atrial fibrillation rate, even troponin, it was reduced, NT-proBNP 30% reduction was there. Important is the hyperkalemia and hypokalemia. Hyperkalemia, which is less compared to others, and the hypokalemia, it was reduced by 50% with the finerenone study. So this is in conclusion that if we take all this important trial of the finerenone, so rationale is that despite availability of the several therapeutic options for the heart failure with MRAF and the HFpEF, including SGLT2 inhibitors, again we do not have anything. I think this finerenone, which plays very important role in the MRAF, and so that's why I think in future I think this is going to the operate probably, because in the MRAF we see that RASI, MRAs and beta blockers, they class 2B. HFpEF again as a diuretic and the SGLT2 inhibitors, the finerenone and the semaglutide. I think this is going to be the next update probably, and that's why I think when there is the heart failure after treating this patient with the for the coronary artery disease, we look for the LV ejection fraction, whether it's less than 40, more than 40. And I think these are the important pillars. There's SGLT2 inhibitors, non-steroidal MRAs, semaglutide or the tirzepatide, which is going to be very important because this is the flow trial. And I think I would like to end, but probably when the patient is having the albuminuric disease and diabetes and the MRAF, I think finerenone, which is a very important molecule, and I think we should add this subset of the patient. Thank you very much.
So, Dr. Bhupesh talk about the finerenone that is non-steroidal. Now with steroidal eplerenone, because more studied in ACS, so as well as heart failure patient. And this talk will be delivered by Dr. Jagdish Shiramat. He is a well-known cardiologist in Western India and practicing in Pune. Over to Dr. Jagdish Shiramat, sir.
Thank you very much. When the first flyer was sent to me, I knew I was on the weaker side because it is a era of finerenone these days. Clicking all the time. Yeah, when the flyer was sent to me, if you see, it was mentioned as LVA 40%. So I prepared my talk according to 40%. Now it is quietly made into 42, put you and finerenone probably. Apart from jokes, I feel one has to look at the pathophysiology of this case. If he is a hypertensive and he is on 42, he is reduced ejection fraction. And if somebody was 35 and now become 42 by treatment, he still reduced ejection fraction. Only those patients, maybe amyloidosis, something infiltrative, and they are sitting between 40 and 50, would we call them as the medium range ones or so? They could behave like the diastolic dysfunction types. I was expecting all these guidelines to be shown in favor of finerenone. And of course, in all these guidelines, what we see is heart failure is not mentioned much because they've come a little later. And in the case that is given to me, in fidelity study, what are the inclusion criteria? They were type 2 diabetes, CKD, optimized RAS, serum potassium below, all this was there, and all the other characteristics. But the LVEF fraction was not there in that. And of course, it showed wonderful results. So then I started thinking probably I'm losing side of the debate because obviously it's a finerenone loaded debate. So I started thinking, who is an expert? Expert is not the one who collects facts. So the factual data was actually, in such a case, could be loaded in the favor of finerenone. But as I said, who is an expert? He's not the one who collects facts, but he's the one who connects the dots. So let's see if we can connect the dots and think something different other than finerenone. So this patient here, actually the last line was that people with HFrEF were eliminated or excluded from the trial of this fidelity trial. So obviously we are looking at, if a patient has heart failure, it has to be the olden MRAs, the proven MRAs like the spironolactone or the eplerenone group. So this 45-year-old, I think LV dysfunction or 40% or 42%, I would still treat him in terms of reduced ejection fraction, not as a medium range, because he is a hypertensive, he has had PATCA in the past, so his LVEF is clearly dropped from above or has improved with treatment. So in this case, in particular case, there is no doubt that it has to be eplerenone that needs to be used. And all the trials that are used for eplerenone, for the initial trial were of acute ST elevation MI, slightly older trials, we all know about these trials. And then it's in the longer chronic heart failure segment, sir. This is one trial in which there were almost 2,700 patients followed up for a reasonable period. These were LVEF less than 35%. And of course, 25 to 50 milligrams of eplerenone showed a good clinical improvement with whatever you think of death or repeated hospitalization, all was reasonably proven with eplerenone. And eplerenone and spironolactone are not different drugs. They are like a little same action, little selectivity, and little side effect difference. So whatever could be said about RALs could be said about eplerenone also, if you can project it that way. And that's why if you see the ESC 2021 had 1A recommendation for HFrEF, and later on it was a 1A reference for HFrEF also. Landmark trials, if you pull up all the MRA trials together, the ones which are completed are the RALs we know about. FSS HF is eplerenone. ARTS HF is now on finerenone, and which is above, clearly it is in the diastolic heart failure or FPEF patients more than 40% EF. And completed on MR and FPEF trial are the TOPAC trial, finerenone HF trial, and there are ongoing trials which are also on spironolactone still going on. And of course, more data would come in the future related to eplerenone. So if you do a patient level meta-analysis on MRAs in heart failure management, on the right hand box, if you see that side, you'll see that maximum benefit, if at all you have to see, leftwards towards from the vertical line still stands the eplerenone group. Overall MRAs are definitely beneficial, and finerenone is crawling up. Like all these bigger trials of finerenone are still on not heart failure patients. If you have heart failure patients of any type, except for the new trial, it's still, the data still favors eplerenone. One more factor I thought was, if somebody has a hypertensive heart disease and failure, finerenone is not a great antihypertensive drug. Like we consider spironolactone or to milder variety of eplerenone, the blood pressure reduction with finerenone is at best modest, and it's not such a good antihypertensive agent to use. Obviously, it cannot be a stage 4 treatment for hypertension or difficult to treat hypertension. And if you see this trial, ARTS HF trial, in which the reduction in NT-proBNP was compared, if you see, they all, bottom line is they are similar drop of NT-proBNP between finerenone and eplerenone. But look at the doses. Here are the standard doses of eplerenone, and here are the doses of 20 and above. That is where it starts matching. And I don't know how many times we will be able to use this drug in CKD. So if you want to use finerenone in CKD, so many times we will still stay to 10 milligrams. And look at the 10 milligram data, it is clearly inferior to eplerenone data. So I would still consider drop of NT-proBNP for a clinical use, probably more useful with eplerenone. And look at this data related to finerenone. All these trials, wherever there is a heart failure, finerenone doesn't come into picture. Whenever there is no heart failure, finally it is a class 1 indication. So I thought of the debates so might bring in some masala. I thought Sonu Sood would be like spironolactone. It is, the photo is shown to think of gynecomastia also. Then it's a proven drug, old one, it's been around for some time. Then came a medium range, another hero, Aditya Roy Kapoor, did his best, proven benefits or proven entertainment values. But the new kid on the block is expensive and expansive. It's going to be a phenomenon in the future, that's what is said. But that doesn't demean Aditya Roy Kapoor at all. It still continues to be useful for the industry and for the entertainment part. So take home message is the steroidal MRAs are recommended class 1A in patients of HFrEF with GFR more than 30. The steroidal MRAs like eplerenone reduce the risk of composite CV death and heart failure hospitalization in HFrEF patients, and non-steroidal MRAs like finerenone reduce the risk in the medium range or FPEF patient, the true medium range ones. Addition of eplerenone to standard therapy within 24 hours in MI, we know that is beneficial. And patients with worsening HFrEF requiring hospitalization and who have diabetes and CKD, the reduction of NT-proBNP levels are similar with both the drugs, but I would still, as I said, the 20 milligram use of finerenone in this patient would be not adequate. So going back to our case should rest actually here the moment we mention, consider this case as a reduced EF patient. So I feel clearly in this patient, I would certainly use eplerenone as a drug of choice. Remove telmisartan, use Ernie. Remove torsemide, it's not required. And adjust GDMT in such a way that in 6 months' time, he would easily cross 50%. And then you start wondering whether it is HFpEF or HFrEF. Thank you.
Questions?
Yeah, I think for fine arts, the data was already shared by both the speakers, beautifully suggested. And then, yes, it was deliberate to make it 42 because at 38 you would win hands down. Yes, Riaz, your
Yes,
comments?
so that's what sir has nicely told, that the question was framed in a way to, you know, add up to, because if it is was a heart failure with reduced ejection fraction, definitely eplerenone has much more data and more kind of say more robust data available already since long. So I think this patient comes to a cardiologist, definitely eplerenone would be the go-to. But if you think of the CKD and the albuminuria, the proteinuria, what he is undergoing, I think if he goes to a nephrologist, he will be more biased towards Finrinone now. So it's a case for both the things, I think. And with time, with the more trials with Finrinone on heart failure, we can definitely get an answer.
Would that difference of EF by 2% make a difference in the understanding of the patient?
I think 38 will be 42 by the same cardiologist done on this different, if the patient, the operator was blinded for doing the same echo of the same patient on the same time. So I don't think this 38, 42, but I think the science, we have to understand how science evolves. Science evolves from the safest patient to the worst patient. You cannot start a therapy for a therapy where, or a disease where already existing strong therapies are available. If you have a disease which is an orphan disease, like say PAH, like say cardiac amyloidosis, like say cardiac sarcoidosis, which are otherwise not reversible or treatable, then you can initiate a study like that. But for a disorder like heart failure, where you already have a therapy, especially MRA segment, when you already have one therapy, you'll have to come from safer patients. FDA will not approve a trial in sicker patients when the standard of care is well established. And that is the very reason for an P2Y12 inhibitor to come, you'll have to compete with aspirin. And now with clopidogrel, when you talk about. And that is the reason probably that unless we end up with a trial which is a head-on comparison between spironolactone, eplerenone or finrinone, this kind of a scenario and options will exist. And it's fair enough for the patients to get benefit of. So as of now, yes, somewhere that cutoff will come. 40, the trial started as 40, it could have been 35, it could have been 45. But we'll have to go by the inclusion and exclusion criteria.
These are arbitrary lines.
No, I'm
There
Arbitrary.
are no rules and regulations for 40 and 50.
Absolutely.
So there is just the trial purpose. All arbitrary lines they were created. Whether the patient is having albuminuric kidney or not, I think here that is going to play important role.
No, apart from the EF, I would think what this patient is really of is actually of EF
Heart
with
failure?
reduced ejection fraction. Is a reduced ejection fraction variety, not the preserved EF.
Now this is interesting because Finrinone, if you look in the Fidelity and Fidelity trial, both actually in diabetic kidney disease, heart failure hospitalizations were reduced, but they did not include patients who were of heart failure. Which means if you have pre-existing heart failure, we don't include you, but if you are diabetic kidney disease, we'll include you and you will not get admitted for heart failure. So it again depends on the inclusion exclusion, and of course the molecule probably will have an action across the board, but as long as that data emerges, I think we'll have to go by the
This is
inclusion
more
exclusion
sicker
criteria.
patient in the fine arts setup because admission for the hospitalization of the 30 days they included class 2 to class 4.
Correct.
So I think there are more sick patient in this trial.
Right. So that's one trial. So any guideline will get it only after 2 trials, but then there are a lot of therapies that are on 1 trial, like Victoria for very sick what? You have 1 trial and you still have class 2A indication for it.
I think another diabetic drug, semaglutide and
Arni and everything is of course approved. Yes. So that was the question here. Can we go to the question? That's quiz. Any other comments from the panel? Dr. Rohan? Dharmesh? Kunal? Anyone else? What UACR is cut off for initiating Finrinone? How much UACR you want to look at in the urine of the patient? 30 milligrams, 300, 3 grams, 300 grams per gram. So grams, milligrams, 30 or 300. It's a ratio. So you of course do a urine and albumin, urinary albumin, serum creatinine, urinary albumin creatinine ratio. That's what ratio you look at to define the therapy. If we can see who gets this one right. Last time it was Shyak. 8 people got it right. So more than 30 is correct. So basically, it's anything which is albuminuric, so-called microalbuminuric, and detectable on a dipstick also. If you get macro urine RM, albumin plus will anyway naturally qualify. So even if you are thinking UACR is costly and you do a urine RM and shows albumin positive, you can start the patient. Can we have the results? Results, please. Who got this right? This is on Mentimeter. Go back to the question if you can see. And in the meanwhile, this is the EGFR criteria and cutoffs, how this was looked at the albuminuria, A1 and G1, A and G, GFR, and the albuminuria. That's the classification, new classification that you have for these kind of patients, where G5 would qualify as less than 15, albumin 3 milligrams, 3 to 30 and more than 30 as A1, A2 and A3. G1, G2, G3 and G4, G5 as 90, 60, 45, 30 and below 15. So thank you very much. And